Maria Hawley Mowat and her friends gather to say goodbye to Maria's husband, Doug. On November 18, 2008, when Doug suddenly and unexpectedly passed away, he became the first donor after cardiocirculatory death in Western Canada at St. Paul's Hospital, Providence Healthcare in Vancouver, British Columbia.
These are calla lilies, which were the flowers at my wedding with Doug, and these are our wedding bands, which I'm going to float out with the ashes, tie a weight to them, and sink them to the bottom, let them rest there. So maybe a couple of fish will get engaged or something. So we'll see. Doug and I were partners for 14 years. He was my soulmate. He drove me crazy by calling me, texting me, emailing me 50 times a day. But having that not part of my life anymore has been a very, very difficult adjustment. And I miss him tremendously, but I'd do anything to have him back. Go, Dougie, go! Go, Dougie, go!
There are kind of three different ways that people can donate their organs. And so the first way is that, I can give them to you, or I could donate my kidney to a son or a daughter, or I could donate part of my liver, and that's well established. The second way is that after a person has had brain death, and so one avenue for donation is the patient has a heart that's beating, their brain is not working completely, it's not going to come back, and we take them with a heart that's beating into the operating room where they do organ donation. The third category is where you have a patient who you know has very severe brain damage, but there is some activity in their brain. And you make a decision based on what their neurological outcome is going to be, that they're not going to recover to the kind of a life that they would want, and you've made a decision to go to comfort care. Once you've made that decision and you've decided that ongoing care is futile, at that point, a family may elect to consider donation when the patient has died. And so in that case, you've got a patient that you change to comfort care, and they go through the same process of naturally dying like would normally happen under those circumstances. And then after their heart has stopped, then they can have organ donation done. Now, there's a time limit in terms of organs completely becoming unusable for donation. And so that's where the donation after cardiocirculatory death is a little different from what we've been doing in the past.
Being the attending physician for the patient, my responsibilities were to actually ensure that I thought the patient would be better managed by going to comfort care measures and eventually withdrawing life support. So the decision to do DCD should not interfere with that decision-making process. So actually, with that family, I treated it just as a normal family that I would treat in any other patient in the ICU. You first deem that the patient should go to comfort care and have withdrawn life support. And then afterwards, that's a discussion that takes place after you've made that decision. That decision should never precede the decision to withdraw life support. And that's a very important fundamental part. And the other thing that we do here at this institution is that we ensure there's a second physician who can take over at that point. And I, as the primary attending physician, can maintain my relationship with the patient and the family in accordance with the efforts that this patient is my primary concern. So, and that in essence is, I believe, the best way to manage these patients, is to have an attending who's always going to be just an advocate for that patient and that family. After you have the discussions of going to comfort care or withdrawing life support, then at that point, a member of the team or the attending can ask if that is something that the family would consider or the patient would have considered. And from there, if the answer is yes, then at that point, I feel it's prudent to get another physician involved with those discussions further.
If he died within an hour, there were certain gifts that he could give. If it looked like his dying process was taking longer than that, then certain gifts would not be appropriate and other gifts may still be appropriate. And so that was where the family understood that there was going to be a time where if he died, we would be needing to move him fairly quickly. And so we explained around the time process, and we explained that he would go to the operating room once dead for organ donation. And so if it didn't happen within that first time limit, then we'd continue to do all the things that we'd regularly do with regards to comfort care.
My first reaction was, did I agree to take Doug off life support too soon? Perhaps so that BC Transplant could use his organs in a better state. But I was reminded, and rightfully so, by Dr. Soronis that as soon as we took Doug off of life support, he died within, I believe it was 31 minutes. And that's the reality. So it was the right decision.
For me, I started to get involved in this because families didn't really seem to understand the nuances between brain death and circulatory death. And I had families asking me, if he was going to die, why is it that somebody couldn't use their organs after death? And so families are what drove me to kind of push this process along at St. Paul's.
Well, when Greg came to see me about 4 years ago, we talked about the whole experience at DCD. He told me what it was about. And I started doing some research, and I said, one thing that would be important is for us to work in concert with other Catholic facilities in North America. So I contacted a number of friends in the States who have been doing it for 10 or 15 years in their facilities. So I gathered their process, the different ways they went about it, the ethical understanding. And then they started doing it in Toronto at St. Mike's Hospital. And so when St. Mike's spent 3 years going through the process, we asked to borrow their process. So what the important piece for the mission is, are we consistent with other Catholic facilities? And in doing that, it shows that we're working in harmony. So we're slightly different with St. Mike's in a couple points, but we're totally consistent with Ascension Health, which is the largest Catholic healthcare provider in the United States. And we're very much in line with Providence Health, which runs the west coast of the United States and Alaska. So there's always variations, but basically it's the same principles which guide us. So the mission is lived by being true to your ethics, being true to the values, the respect, the dignity. And most of the mission comes alive on how we handle the actual situation, the respect, the integrity. That's really where it comes alive.
In this case with Doug, when he first arrived in the ICU, it was about saving his life. So DCD, organ donation, all of the above is not even an entertaining thought in our heads at that moment. So meeting the family for the first time, it's with hope that we can actually reverse what has occurred. It's not until that the physicians and all the consultations and all the teams that are involved in the care that the possibility of DCD in this case came up. It was days, I think it was about 4 or 5 days after he was admitted that we actually started entertaining that thought. So, but to be honest, the family actually brought it to our attention. So as the social worker though, I find DCD opening doors to more of the family and patient's wishes. I try to obtain psychosocial information, as much of the background, get to know our patient Doug outside his diagnosis. So I'll try to gather who he was, what happened, where the family are at, and actually their relationship with the family. And then, when appropriate, I will translate that to the medical team to help them multidimensionalize their patient, because it's easy to actually keep them one-dimensional. They're quite sedated, they're quite compliant, and they're quite sick. So as the day goes on and as the days go on, we get the family involved in the care of the patient. We make them feel part of the team. We try to gather as much information, in this case about Doug, as possible, so we humanize him. We hear their stories. Again, that's where I try to come in. I listen to their stories. Each person has a different relationship with the patient. So I try to validate their relationship. Takes some time, but it's actually quite interesting work because it just adds to Doug's life. And that's a life upon a mission that we're trying to save. So this is a process that we do for every patient that comes in the ICU. But in Doug's case in particular, as the days went on and we saw that there was probably not a chance of neurological recovery, we wanted to get more intimate with the family, or at least I did, and closer to them, because I knew as my job that I would be having probably an ongoing relationship with someone in that family.
We were treated with kid gloves and a lot of respect, thankfully so. I remember that period of time all too well. It was 5 months ago, but you know, your nerves are frayed. That you're not getting any sleep, and you know, basically I just felt sick to my stomach all the time. So trying to make major decisions that affect that would have affected Doug's life, his son's life, my family's life. It was through the support, I think, of the ICU and their team that helped me stay calm and try to make the best decisions that we could as a family.
I had time to review the patient's chart because he wasn't a donor yet. He was a patient who was not going to survive his injury, and his family had expressed interest in organ donation. So I had a look at his chart, talked to the people looking after him, and at that point we went in and met with the family. And part of our job is to do a medical social history, make sure that the consenting is done and that they understand the consent, what that means, especially what it might mean in a situation of donation after cardiocirculatory death, because if the person does not die within a certain length of time, we're not able to use them as an organ donor. And the family needs to understand that, because their hopes are being built up, that this is now something that might give them some meaning. They focus on, now this person can be an organ donor, and that might not work out. So there is that possibility of a disappointment for them.
It's about mobilizing the team and mobilizing the team quickly. And it's the resources that we're all familiar with using, and it's just about bringing those people together so that we can talk about how we're going to make it happen. So, I mean, obviously it includes links to pastoral care. We have a palliative care outreach service that sometimes we'll consult with. Social work, obviously, the physicians, and nursing as well, and also our RTs, who are key. And they need to be included in the process. They can't be left out, because they're there and they're impacted just as much as the person caring for that patient.
I don't think the day-to-day management changed very much, although we all were aware that this was going on, and also that it was the first one that had been done at St. Paul's Hospital. So everybody was interested, and the family were of very serious concern to all of us that they would get enough coverage and somebody to be with them at all times and to help them any way they needed. So that was at the forefront of everybody's mind. But the rest of the patient care continued as normal.
I was able to be very conscious of trying to preserve the patient's dignity right to the very end, and at the same time I felt that impacted on how the family experience went for them. If they knew that he was well cared for, then it all rolled into one, and I felt that would impact on their memories of the experience and their grieving process if I could optimise his care at that stage. Well, with regards to preserving the dignity of the patient, I think it's just the way you approach the patient, the way you talk to them, even though you know that they're going to die imminently. I still talk to patients as if they can hear me. I observe basic hygiene needs that try and help them to look comfortable for the family, and that they're free of pain, and that and I'm always aware that the family will always remember those images in their grieving process. So that really sticks in my mind, that it's really ultra important to do that. And with the family, I think communication is the ultimate thing that we can do to make them feel as comfortable as possible and as involved as possible, because I think a lot of fear for families comes from what they don't know and what they're wondering about that we're not telling them. So I think if we can be open and communicate with them, then we actually go a long way to making the process a little less stressful for them.
We have a very short window from the time that a patient is taken from treatments for cure and only comfort care. And during that time, if the patient does not, it is not declared dead, then they will continue on to the form of palliative care that we normally continue with. But we have to be prepared that if the patient does in fact die, that there is a very short window to move the patient. And so that time, everything else has to kind of that takes precedence. And so I had to clear the hallways, clear the room, make sure there were no families in the near vicinity who would be in the way when we had to move the patient because of time. And personally, it was a little difficult. I mean, none of these things are easy. You're looking at the death of a person, and the quickness of it is personally very difficult, because we're used to, when we change from care for cure to care for comfort only, we're used to it being a calm environment. The patient may die suddenly, but it's expected and there's no running around. Everything is calm. Whereas in this case, the process is the same up to the point where we end up going to the operating room, and then it's very fast and very dramatic, and I think could be difficult for families to deal with, and also for staff.
One of the things that came up during that was that it wasn't business as usual, from the perspective that it was something new. And so there were a lot of questions that came up during the actual process. And one of the things that became important was actually the strategic placement of where that patient was. So we had originally had them in one of our private rooms at the far end of the unit. We ended up learning from that instead of doing that, it would be better to have them close to the entrance and exit door for the unit. Because what was happening is that there were a lot of family members walking through the entire unit to the very other end and all the way back. And I guess we sort of learned from that it was uncomfortable, not only for the staff, but for the family. And so we wanted to keep that proximity of where that room would be to where our patient comfort room was.
During a DCD, it can get quite complicated with the fact that in this case, when we do have comfort measures implemented, and the patient is declared that they've died, the family have about 1 minute to get removed from the room, so we can actually take the patient to the OR and sit there for about 5 minutes and are declared dead once again before they go into the OR. That has to do with organization and communication with the family. So again, our medical team will describe what we need from them, and social work and pastoral care will reinforce it. And after the fact, after the patient is declared deceased, we gently and politely remind them of what we actually went over, about what we expect of them. And they have to say their goodbyes quite fast, and then we escort them outside the unit. So during a DCD, it is extremely important to give them space, their time, because we don't know if it's going to be 10 minutes, 30 minutes, and if it's after an hour, well, then the patient's palliated. But to give them that time and address their concerns. It could be as simple as a water because they're dehydrated. But give them their space, give them their time, and then gently remind them that this is what we need from them. Once the patient is removed and taken to the OR and those doors to the ICU close, the family did not go back into the unit. However, they stayed outside from anywhere between 30 minutes to actually about 45 minutes, just sort of lingering around and talking. But again, more questions came up. Now what do we do, right? So here they've gone through all this, but they actually aren't aware of actually how to do a funeral or what they should do next. I'm always looking around for someone who might have 2 feet on the ground, who can listen to the directions, because unfortunately after someone dies, there's business to take care of. And in this case, it was the patient's father who I was able to have that conversation with, and that I would be calling him within 48 hours. And part of my other job is a 48-hour follow-up, and I won't call the whole family, but I'll call those who I think should be called just based on my relationship. And in this case, it was the father and, of course, the patient's wife, Maria. And then the follow-up could actually end after 48 hours because everything's okay. Or their grief gets so strong, they'll call me weeks later, or there's insurance paper forms. I mean, we take care of these families from basically the beginning to the end. And it doesn't stop until it actually stops. And in this case with Maria, I still have an ongoing relationship with 5 months later, partly to do with the video, but also because we've made a connection. And she's really experiencing some tough times and trying to work through this grief.
We need to give the family the opportunity to say to them, hey, did you know? This is different. This is something that we're doing that's new, and give them the credit that they've got the capacity to deal with that. One of the things that we've done is up a little checklist for our nurses who are in charge to sort of say, okay, these are the things that you need to think about when we have a case, because they're still infrequent. So that little reminder is really helpful for them to decrease anxiety. In addition to that, I think it's important that when we have the nursing staff, that we just do that check-in, because all cases are not alike, they're different. Debriefing is essential. It had a much larger impact on the OR than we had anticipated, and we actually didn't learn that until we had brought somebody else in to debrief that group separately. One of the obstacles is having difficult discussions. These are not easy discussions to have. There's lots involved clinically from an ethical perspective that if you aren't able to say, well, how do you feel about this, and be honest and transparent and saying, oh, I'm really not comfortable with that, then your team can't hope to implement something like this. You may not all have to ethically agree with one another, but the principles need to be laid out and they need to be there.
I was actually contacted by BC Transplant beforehand. They informed me that the policies or the rules had recently changed, and that donor families and recipient families were, through BC Transplant, allowed to contact one another if there was agreement on both sides. And of course, I was very anxious to hear something from the recipient donor. And I received a card in the mail shortly after, and it brought a lot of joy in the form of tears to my eyes. Seeing the person's handwriting, their heartfelt thank you. I also took the letter and showed it to other members of Doug's family, and I know they felt the same way that I did. That here was, some proof, some living proof through this recipient's handwriting that, in fact, Doug had given a wonderful gift. Doug was a very generous, gorgeous, handsome, athletic individual. He was the most giving person I've ever met in my life, and organ donation was his final gift. And I know that he was well loved by his friends and family too, and nothing will ever replace him. I just miss him.
Later on, they took his car, drove on down where the beaches are. He wrote her name in the sand, never even let go of her hand. Somehow they stayed that way for those 5 days in May.